Chapter 2, From Designing Care, Aligning the Nature and Care Management of Healthcare by Richard M. J. Bomer, 2009. An interpretation by 5 medical students at Karolinska Institutet. Certainty. What certainty? How certain is the medical evidence we use? We often take for granted that the guidelines are based on profound certain data, while many of the clinical decisions are based on the individual physician's earlier experience. The ideal healthcare for the healthcare manager is care that is certain, predictable, and repeatable, where tools from production can be applied. However, it's not that simple to apply tools from production industries on healthcare. Humans are difficult to standardize and makes this industry complex. The nature of medical evidence. One can argue that medical knowledge is incomplete. Are all decisions that physicians take in their day-to-day practice based on evidence? What's this evidence built from, and how certain is it? These are some questions we will try to answer in this presentation. Randomized controlled trials are the best study types and renders the highest level of evidence. Despite this, one should be aware of 3 types of errors. Firstly, there are methodological errors. One should bear in mind that there is poor knowledge about study design, and to some extent there are cheaters. Secondly comes to statistical errors, where scientists or physicians analyze statistical data without thorough statistical understanding. Thirdly, there is the risk of biased reporting of results, with, for example, selection of positive results and influence from the industry and biased interpretation by media. There are 2 ways of looking at science. Either it is certain or it's uncertain. Certain science includes medical conditions where there is a best practice agreement. The consensus regards, for example, beta blockers in myocardial infarction, ACE inhibitors in congestive heart failure, and warfarin in atrial fibrillation. Here, guidelines and course of action are applicable. But what happens when the science and evidence is uncertain? Medical evidence is a constantly evolving process and never static. When evaluating the level of evidence of a study, there are several different scales used over the world. Naturally, this gives room for a wide range of interpretations. Hence, there are some things that can be standardized, as mentioned in the previous slide. So what happens when the evidence meets the patient? Patients most likely have multiple conditions, but generally clinical trials evaluate the effects on only one particular disease in a specific populations. So that leaves the physician with the uncertainty of combining the evidence from different trials, which may lead to treatment interactions. A study population is not equal to a patient, and of course patients are individuals. The patient has its own values and preferences, and this may very well differ from the physician's perspective when it comes to, for example, choice of treatment. A treatment that, for the medical point of view, is a simple and reasonable procedure, like a blood transfusion, may, for some patients with, for example, religious views, not be an option. On the other hand, there are situations where the patient is left to entirely make the decision about whether, for example, to proceed with a knee replacement or not. So the best medical practice may not be the best treatment for the patient. In conclusion, this chapter is focused on the variation in the quality of evidence, how it's used to suit medical practice, and the nature of patient-to-patient variation.